going to go ahead and get started. My name is Shandy Blackston. About 2 years ago, I was diagnosed with breast cancer and started my journey. And as a matter of fact, as I was laying in my hospital bed post double mastectomy, this lady here reached out to me. If it had not been for Team WHIP, I don't know where I would have ended up. They have been so supportive, so I'm very proud to be a part of Team WHIP. This is our first workshop with the Teaching, Empowering, Advocating. It's our T project. It was made possible by East Alabama Community Foundation Trust Grant. And we are going to have two speakers today. The first being Arkira Dowdell, sorry. She is an oncology certified nurse and breast health clinical navigator, which I firmly believe everybody needs. And I'm sure we have all felt that loss at diagnosis, and it's ladies like this that have led us and guided us and calmed us. So we're gonna let her take it away, and she talks about advocacy for patients, both personal and professional, and you're a Daisy Award winner. Congratulations and thank you.
Good morning, everybody. Anybody that knows me knows I can talk to a brick wall, but presenting is something different, so just bear with me. Like Ms. Shandy said, my name is Arkira. I am a registered nurse. I've been a nurse about 17 years, and the last 9 have been in oncology. I'm also a breast cancer survivor. It was 6 years, it's 7 years in February. So let's just get started. So we're just going to talk about breast cancer facts, modifiable risk factors, things you can change, things you cannot, what screening is recommended. If you have a screening that's abnormal, how we progress through to diagnostic, whether it ends with breast cancer or ends with a benign process. Then we'll talk about meeting your oncology team, what that's like, and then you'll get to talk to Dr. Johnson, who's a medical oncologist. All right, so basic breast cancer facts. Breast cancer is the most common cancer in women with the exception of skin cancer. It's also the second leading cause of death in women, second to lung cancer, I believe. So every woman has a risk of breast cancer. 1 in 8 women will be diagnosed. And then it's also a myth. A lot of people think men cannot get breast cancer. It's far less common. As you can see, 1 in 755 men. In 2025, it's estimated there will be about 316,000 women diagnosed with invasive breast cancer. So that doesn't include I won't call it pre-cancers, but like the stage 0 non-invasive breast cancers. Also about 2,800 men. Along with that, even though it is the second leading cause of death, there's about 2.9 million survivors just in the United States. All right, like we said, risk factors, some of them you can't do anything about, like your age, your family history, ethnicity, but the ones that we can do something about, we call those modifiable risk factors. So, like we said, a couple of things. You can't do anything about being a woman. You can't do anything about, how old you are. But there's some things that do affect it, like having a child before the age of 25, breastfeeding, like 15 months. Those things help, but they're not like a black and white relationship. It's not just because you had a child before the age of 25 that you have a lower risk, because really right after you have a baby, that risk is higher immediately. So the only things that we have like measurable decrease of risk for is exercise. American Cancer Society recommends that you have 75 minutes of vigorous exercise or 150 to 300 minutes of moderate exercise per week, or some combination of those. Obviously maintaining a healthy weight, and then alcohol. So I like to talk about this because sometimes people think if you just have one drink a day, that doesn't matter, but just one drink a day for a woman increases the breast cancer risk to about 10%, and if you have 2 drinks every day, you increase your risk by 20%. So, you know, 1 drink a day doesn't sound like a lot, but 1 drink a day increasing your risk by 10%, I feel like it's significant. Yes, ma'am.
I'm sorry, when you say 1 drink, what type of drink?
So American Cancer Society just says alcohol. They don't specify, you know, if it's wine or liquor. So I'm not sure. Do you know?
I don't know their specifics. Most of it, when we talk about like 1 drink per day or 2 drinks per day, we think about like 1 can of beer or 6 ounces of wine or 1 ounce of liquor. It's kind of defined as a drink. Which, yeah, for our society in the southeast, that's not a lot.
Alright, so if you have a family history of breast cancer, a known genetic mutation in yourself or first degree relative, first degree is a parent, sibling, or child, and then using hormone therapy after menopause. That's also one of the things that's kind of not just clear cut because there's different types of hormone therapy. Some have been shown to increase your risk and some have not. Alright, so screening recommendations. Everyone always says early detection saves lives, and it does. A lot of times with screening, you can find breast cancer before you have physical symptoms. Anytime you can find it before you have anything going on that you can feel or see, we have a better chance at treating you successfully, because if you can find it before it shows up physically, then it's usually an earlier stage. American Cancer Society defines screening recommendations based on average risk or high risk. So an average risk person is someone who has not had radiation therapy to the chest before age 40 or before age 30. So a long time ago, I think they don't do it this way anymore, but like if someone had lymphoma or another cancer or something as a child, they would do just like full body radiation for that type of treatment. Most people haven't had that, but if you have, then you're at increased risk for breast cancer. So not having that puts you at average risk. So no family history, just the average woman. So the recommendations for that is age 40. It says women should have the option. We like to say, yes, if you're 40, you need a yearly mammogram. Once you hit 45, it is recommended that you should have. So 40 to 44 should have the option. 45 to 54 is a yearly mammogram, and then 55 and older, it says that you can have a mammogram every year or every other year as long as you're healthy enough to be expected to live 10 more years. So, and I think I forgot to say what I do. I'm a nurse, but I'm also the breast cancer coordinator. So what I do is, once a patient has been diagnosed and notified, they send a referral to me. I make sure that they have any additional imaging that they need, make sure that they're set up with genetics, get them plugged in with whichever doctor they need. And so, of course, American Cancer Society is the standard, but I have patients that are 25 and I have patients that are 95. Sometimes primaries will say like women over 70, you don't really need a mammogram, but we have a lot of women in the demographic that do have breast cancer. Now, some of them decide there's certain aggressive treatments that they don't want to do because of their age, but if your doctor will order it, it's not going to hurt anything. Mammograms are just low dose x-rays. So with the high risk recommendation, it's just like we talked about with the average, except the mammograms will start at age 30 and you will also have an annual breast MRI. So that would be yearly for both 6 months apart. So every 6 months you would have some type of imaging. Now I was diagnosed when I was 32, and I have 2 daughters. So the recommendation, like my children, it would not be the best for them to wait till age 30 because they need to start well before I would have needed to. So normally it's 10 years before your first degree relative or age 30 if you're high risk. So family history, known genetics, chest radiation. Any questions so far? I feel like I'm just All right, so symptoms of breast cancer, like we talked about, early detection is important, screening is important. but sometimes for whatever reason, patients are too young, and that was my case. Like, I wasn't old enough for a mammogram, so I found it just feeling a lump. So if that's the case, or sometimes people don't get mammograms, either they don't have access to it or don't feel like it's important, but either way, you can have a physical symptom of mammogram. And also, not all breast cancers are found on imaging, so it's very important to do your own breast exams. Doing your breast exam by yourself or having a clinician do it, you're supposed to do that because you need to be familiar with how your breasts feel. If you're premenopausal, the texture and the thickness kind of your breast changes during your cycle, so you need to be familiar with what that feels like. But it's not enough to be considered your screening. A lot of times the most common symptom is a lump or a mass. Most of them are not cancers, but they could be. So everyone needs to know how to do a breast exam. I see like social media campaigns, feel it on the first, just like you would change your air filter or do your dishwasher cleaner on the first. Just make it a habit to do your breast exam on the first of the month, and then also around your cycles. So if you have any of these physical symptoms of breast cancer, you need to notify either your primary or your GYN. So there will be swelling in a breast, skin dimpling, or a texture like an orange peel, how it has the dots in it, breast or nipple pain. If you've never had an inverted nipple or a nipple that turns inward and it starts to do that, that's one of the signs. If you have dry, flaky, red, or thickening skin, meaning like your breast feels normal here, but then in another spot it feels denser or like firmer in that area. Any type of nipple discharge or swollen lymph nodes or lumps like under your arm, under your collarbone. So in talking about the physical symptoms of breast cancer, let's talk about breast cancer in men. It is less common, but men don't have mammograms as a screening option. So for a man, most of the time the symptom is a mass in the breast. But like this slide says, men have breast tissue, but they don't have as much as women. So when you find breast cancer in men, it's normally smaller than it would be in a woman, but because they have less breast tissue, it's often more advanced because it gets into the other tissues in the lymph nodes faster than it would with a woman that has more tissue. And then I have lack of awareness here, not necessarily because men are not aware, but it is a misconception that men don't get breast cancer. I think when they feel masses, they ignore them more often than a woman does, either out of shame or just trying to say, you know, maybe this will get better, maybe I got bit by something, because it often doesn't hurt. So if the man has symptoms, which is the same as female, skin dimpling, nipple retraction, redness, discharge, or a lump, they would also get a mammogram and ultrasound just like a woman would. All right, so let's say you had whatever your screening was, or you don't know what else title boxes are there. Whatever you had your screening, or you found something and the clinicians say the next step is a biopsy. So there's several different types, and I just wanted to briefly review each one. You can have a stereotactic biopsy. Dr. Johnson, correct me if I'm not right on these. Stereotactic biopsy is when they use mammogram to find it. It's usually when it's really early, like if it's just calcifications, not a true mass that can be targeted. They do a light compression mammogram and do the biopsy that way so they can see exactly where to go. Ultrasound guided biopsies are when they ultrasound it, they can see the mass or see something that they can target, so they ultrasound the area and find it and put the needle in it that way. MRI guided is similar to stereotactic in that it's something that you can't target with the ultrasound. So breast MRIs are done like face down like Superman, and your breast kind of hanging this contraption under the table. For the MRI guided biopsy, they will have already done an MRI for you and know what slices or what frame the cancer is, and so they will do an MRI, get to that phase, and there's a little grid on the side of the table, and they go through it and target it based on the previous imaging and the current imaging. It's normally like CT guided. They'll put a needle in that area, and if it returns that it's breast cancer, then we kind of work backwards and start with the mammogram and the additional imaging to find out where it came from. It doesn't happen that often. So once the biopsy is done, they take the tissue specimen and send it to pathology. The pathologist will look at it and tell us if it's a benign process or malignant. Benign is non-cancerous and malignant means cancer. So these are just two images of what like the pathologist sees. The top slide is fibrocystic changes, which is normal. And the bottom is what an invasive cancer would look like to the pathologist. Some benign processes, you'll get a recommendation that you just need to repeat the screening in 6 months. Some of them, like atypical ductal hyperplasia, that's one that puts you at increased risk for breast cancer. So those benign processes are normally removed just to make sure that everything's good.